Hildegard E. Peplow is the creator of the theory of the significance of a therapeutic interpersonal relationship between a nurse and a patient. Hildegard Peplow was born in Reading, Pennsylvania on September 1st, 1909. She was the second of 6 children to German parents. Hildegard experienced the Spanish flu epidemic at the age of 9, which later greatly influenced her journey into the nursing field. Peplow graduated from Pottstown, Pennsylvania Hospital School of Nursing in 1931. She later continued to get her bachelor's in interpersonal psychology in 1943. She also continued on to get her master's in psychiatric nursing and a doctorate of education. During World War II, Hildegard was in the Army Nurse Corps and worked in London, England in a neuropsychiatric hospital. She's often been referred to as the mother of psychiatric nursing, simply due to her contributions to psychiatric nursing as an educator, author, and theorist. In Peplow's theory of the significance of the interpersonal relationship between a nurse and patient, she discussed 4 psychobiological experiences that compel destructive or constructive patient responses. These 4 experiences are needs, frustrations, conflicts, and anxieties. From these 4 experiences and how the patient perceives those is a big key in the relationship that you can build as a nurse with the patient, and also is a big factor in how it moves on to the next phase of this theory. But looking at these 4 experiences, it's easy to see how as nurses these are all things we would easily come into contact with patients as nurses, and in the future as nurse practitioners. It's important that our patients feel that we are attending to their needs and attentive of their needs. It would be very easily for a patient to feel that we're not meeting their needs if we're not attentive. And as you can easily imagine, then that could be a destructive response from the patient if they feel like we didn't care about them. Also, moving on to frustrations. In the medical field, it's so easy for us to see things and diagnoses each day that just become natural for us and second nature. But as patients that are so new to medicine and maybe never have had any complications before in their life, they can easily be frustrated with maybe the terminology or their diagnosis or just understanding what's going on with their body and being sick. So that's also something we have to be very attentive to and make sure we cater to their needs with that. Conflicts. Obviously, we'd like to resolve any conflict in the best manner possible in order to maintain a good relationship with the patient and keep communication lines open. We'll never make any progress with the patient if we reach a conflict and we don't handle it correctly or with professionalism, and they shut down and don't give us any further information. And last, the experience that can be destructive or constructive is anxieties, and that's something that we've heard about from the very beginning of nursing school, and even prerequisites. As we hear about patients having white coat syndrome just from even walking into a doctor's office or to a hospital. People get anxious and kind of uneasy about what's going on there and what could go on there. So it's very important for us to cater to all these experiences and try to make the most of them and make the patient feel comfortable, just in order to keep communication lines open and to build a better relationship with the patient, which is what this theory is all about, is just building a trust and a better relationship with your patient, so you can essentially take better care of the patient and produce better outcomes for the patient. As you progress through Peplow's theory of interpersonal relationship between a nurse and a patient, she continues on to describe the 4 phases of the nurse-to-patient relationship. The first phase of this being the orientation phase, and it's pretty self-explanatory, but this is when the patient and the nurse or nurse practitioner first meet. It's a good time for them to build rapport and trust with the patient. Sometimes this can lead to conversations that may not always be on topic of medicine, but just to establish a relationship with the patient, make them feel comfortable. It doesn't always have to be starting out completely down to medicine and doing nothing but talking about what's going on in the disease process, but just learning a little bit about the patient and maybe even giving some information on yourself to the patient in order for them to just feel comfortable with you. It's also a time for the patient to express their expectations, maybe some concerns and needs that they feel like they need in a provider, and it's based around just establishing a therapeutic environment between the patient and the nurse. The second phase in Peplow's interpersonal relationship theory between a nurse and patient is the identification phase. This phase is when there's trust that's being built between the patient and the nurse. The patient begins to feel comfortable enough to reveal some problems in which the nurse and patient can work on together to resolve. They don't actually really take any steps to making that resolution yet or implementing anything, but it's basically to clarify the patient's expectations of the nurse and explore like their feelings, talk about stress, assist in understanding the type of needs and expectations of the patient through the interaction between the nurse and the patient. The third phase is the exploitation phase. In this phase, the nurse develops a plan of action, implements it, and then evaluates that plan of action. And during this phase, the patient may be discovering new skills or problem-solving characteristics in which they may change some of the manner of communication. They may not feel adequate in some of the new skills, such as a patient that may need to start giving themselves insulin injections. Things like this is something that the nurse needs to assess, make sure the lines of communications are open, and really help the patient understand and create a balance of where they need dependence and how they can maintain their own independence also. This phase, it's very easy for the patient to get discouraged and to shut down their communication, but that's where it comes in to be very important for the nurse to recognize that, reevaluate what's going on with the situation, and see how they can assist the patient in meeting their needs, and while maintaining a therapeutic interpersonal relationship with the patient. The fourth and final phase of Peplow's therapeutic interpersonal relationships between nurses and patients is the resolution phase. So we've had the orientation phase. You meet, build a rapport. Identification phase, identify a problem, and then the exploitation phase, where you develop a plan and execute that plan and reevaluate how it went. And then so the fourth is the resolution phase, and this is basically where the patient becomes more independent, is able to take the knowledge and skills gained during the first three phases and continue to use those problem-solving skills to gain some independence with their health. Also with this, the patient looks to the future to prevent problems and also take the information and learning they gain through the illness experience and apply that to further situations as such. In Peplow's theory of nurse-patient relationships, she also goes on to describe 6 nursing roles that a nurse can take on regarding a patient, and they are all listed here, so we'll go through them. And the first one is the stranger role, and just as pretty self-explanatory. This is any situation. I mean, you can be a stranger to this person. If they don't feel like their needs are being met, that they're being cared for, that you understand what they're explaining to you, or that you care, you can easily become a stranger to a patient, and not get any vital information that they could be providing to you. The second is a resource person for the patient, answering questions for them, interpreting data, treatment plans, giving them information, someone that they feel like they can go to with these questions, and they feel like they're getting adequate answers, and they're being cared for the way that they need, and is they're most responsive to. Next is the teaching role, giving an instruction about the treatment plans, overall teaching them about the medications they'll be taking, and just really anything that has to pertain to the medical field. It's such a foreign field unless you're in medicine. All the terms and disease processes and medication, it's really something that you don't learn about unless you're in the medical field. So that teaching role is a very, very important role in maintaining a relationship with your patients. The counseling role is what she describes next, and basically this is a point where you get with the patient, and they're very comfortable with you, and they're they're maybe not only asking about medical problems, but looking to guidance and counseling, and how these problems affect their life, and how they can get some help from you. And this is, to me, I interpret this is us helping them getting set up with home health, and finding ways to make what they're going through as far as the disease process, and maybe do not new diagnoses and things like that, making those experiences a little bit better for them, by counseling through them, and helping them with what they feel like is a very difficult life circumstance. The surrogate role is essentially being an advocate for the patient, and that kind of makes a little bit more sense to me as I looked further into it as the surrogate role. Helping them to define where the dependence and interdependence and independence needs to rely on with the nurse. And for this, it's just the gist of that is just to be an advocate for them in times that they aren't able to, or maybe don't understand what needs to happen. You can step in and give them guidance on giving them pros and cons to everything, the treatment plans and medications, and just continuing with their care in a manner that feels like they are being truly taken care of. The last is the leadership role, and the client is basically taking responsibility for their treatment, and feeling good about that process, but they still need someone to be a leader in their medical guidance and in their care. So the patient's doing a lot more on their own, they're more independent, but they are still needing a leader to kind of take charge and still give them guidance on the care that they need. There are two main concepts in Peplow's significance of interpersonal relationship between nurses and patients. The first is a psychodynamic nursing, and that is the understanding of a nurse's own behavior, and also the behavior of others, and their difficulties, how they interpret those, and how they react to those. It's really basic principles of human relation, that when a problem arises, that the nurse understands how they react personally, how the patient reacts and could react, and be able to adapt to those. And that's such an important part of being a nurse, and as we continue on to be nurse practitioners, and understanding our own feelings and beliefs, and also being able to read a patient, and how they may respond to certain news, and tailoring that to each patient, as far as like maybe a new diagnosis, or the way they will take medications and how compliant they'd be. It's just very important to be attentive to that. Along with this is the psychobiological experiences we touched on earlier, but just to reiterate those, it's the needs, frustrations, conflicts, and anxieties. And that concept is stems around how a patient will respond also to each of those, as far as the interactions between a nurse and a patient, and it can be either destructive or constructive. And it's so easy to get into a routine as you go in and assess patients and give medications, that sometimes that can be perceived by patients as maybe not meeting their needs, as far as um, talking with them, sitting down with them, understanding who they are, and just hearing their story, and maybe a little bit about their life. Um, and it's just so important that we are attentive to those four experiences, and that we can use those to our advantage in um, proceeding with the interpersonal relationship, and the being therapeutic with that, to make sure that we can provide the best outcomes for the patient. So, in the review and analysis of a theory, such as Peplow's theory of therapeutic interpersonal relationship between nurses and patients, there are a few things that come to mind of what we need to question about the theory. The first one is logic. Is it logical? And this theory absolutely is so logical. Uh, its theory is that the better we develop a relationship with the patient, the better the patient outcome is going to be, and the logic in that is just so clear. As we speak with patients and build a rapport, they become more comfortable with us. They trust us. They trust that if we say, we recommend you to take this medication, if we have that rapport with them, it's more likely that they're going to take that medication, take it as it's prescribed, and listen to our guidance on that. And just the logic of this is just so relevant, and not only to nursing, but really in anything that deals with relationships between two individuals. The ability to establish a relationship, to recognize the experiences that you have with a person in this relationship, whether that experience is constructive or deconstructive to the future of the relationship. It's vital to be able to understand that and recognize that, adapt to it, and create a better relationship with someone you're working in any capacity, really. So the relevance and logic of this theory, there's no doubt that they are relevant to the nursing field, um, you know, greatly, but even to other fields. I am positive that this theory and concept of building an interpersonal relationship, not only is between nurses and patients, but can easily be used between any interaction between two individuals. Um, Another thing that you have to look at is the flaws of the theory. This theory, really, one of the biggest flaws I can see is doing research with this theory. It's much more qualitative than quantitative, simply due to each interaction with the patient and nurse. The patient would have to give feedback on how they felt, how their needs were met, are they frustrated, how conflicts were resolved, and what their anxieties were, and how they felt the nurse responded to those. So that would be a flaw, that just the research side of it, the ability to do a mass amount of research would be much more difficult, just due to the qualitative side of this research, because you have to start off figuring out their experiences. From there, what phase the nurse and patient are in together, and how they feel that's going. And once they've completed that, then even finding out which of the six roles that the patient feels the nurse falls in, specifically to them. So it's very in depth in all the things you have to look at. Maybe not just as simple as gathering, just numbers or data that you put it and do statistical analysis on, but it's more, interpreting the patient's feelings and seeing how they respond to the relationship. But overall, the logic and relevance is there. The flaw, there is a flaw, but it's minor once you, in the big scheme of things, because of the quality that you're obtaining with this therapeutic relationship is um, just priceless when it comes to increasing the uh, outcomes of a patient and the desirable outcomes. Just caring for the patient better, and overall, when the interaction is done and once you reach that resolution, that the patient feels like they have truly been cared for and gained your trust, and you've gained their trust. And so for the future interactions and complications, um, they'll all go much smoother due to the relationship you built with that patient.